Welcome back. I hope you had a good evening yesterday. I think it was a very full day. I hope you managed to relax over dinner and meet some interesting people. Somebody new, perhaps. We gave it. Robin Osborne, are you in the room? You are. Could you just stand up? I mentioned Robin yesterday about the Harkness Fellowship. Try, if you are interested in that, please try and catch her in one of the breaks. So, you're just a silhouette to me, Robin, because the lights are rather powerful. Thanks for that. Okay, so let's get on. I'm Andy McKeon for the purposes of today. I hear he's okay. Those of you, we reported yesterday that he's rather unwell. So I'm stepping into his shoes. He and the Nuffield directors are really responsible for this programme. I'm, as I said yesterday, just basking in reflected glory, for which I can really take no responsibility. Let's get on. We've got a session now on reforming health and public services. So that's looking a little bit more widely beyond what we tend to do in sessions like this, which is rather focused narrowly on where we are. Hugh Taylor is going to take us on, and we've got Gus O'Donnell, Julian Grant and Sarah Pickup. Hugh, over to you.
Thanks very much, Nigel. My name is Hugh Taylor. I'm currently the chairman of Guy's and St Thomas's Foundation Trust, and also on the board of the Nuffield Trust. So we're focusing this morning in our first session on public sector reform. In a past life, I worked for a Secretary of State whose almost first sentence to me when he came into office was that the one word he would never allow to pass his lips in any form of public communication about health began with an R, and that was reform. He did quite a lot of reform, actually, but he didn't believe in talking about it. So, nevertheless, we're going to talk about it this morning, and we've got three very, very interesting people to talk to us about it. Our first speaker is Gus O'Donnell, Lord O'Donnell, my former boss, Cabinet Secretary, as close as it's possible to be to the seat of power and to the mission of successive governments to deliver change in public services, and now Chair of Frontier Economics. Then Professor Julian Legrand, who's the Richard Titmuss Professor of Social Policy at the London School of Economics, a great guru of health economics and reform, who was, of course, an advisor to the Blair government on health reforms. And then finally somebody who's actually responsible for doing something about all this in public sector reform, working at the sharp end, Sarah Pickup, Deputy Chief Executive of Hertfordshire County Council, and she's going to illustrate how you make change happen on the ground in a local authority, bearing in mind that although most of us in the health system like to whinge about money, local authority have really had to bear the brunt of huge reductions in potential spending and make changes accordingly. It'd be very, very interesting to get her reflections as well. So I'm going to hand straight over, first of all, to Gus, and then we're going to have a conversation with you after they've all spoken.
Great. Thank you very much, Hugh. We're going to do about 6 or 7 minutes each. We're going to start a very big picture and then go to implementation with Sarah at the end. So big picture, I want you to imagine that it is the middle of May 2015. We have got a new government in place. It's something incredibly unusual for this country. It's the first ever fixed term parliament where they've known it at the beginning. They've got 5 years, right? Never happened before. So what are they going to do? Well, let's imagine that first cabinet meeting where the Prime Minister sits down and says, look, I'm going to have a 5-year spending review. Not a 1 year, 2 year, 3 year spending review. Got 5 years. Okay, we'll have some contingencies for if the economy doesn't quite work out, as the way the Office for Budget and Responsibility tell us it will. And what I want you to do is to go and maximise well-being. Right? Off you go, for the public. Right? That's the key. And we're going to allocate money out so that we maximise well-being. Now, this is different, right? This is very different. Suddenly we're in a new world, right? So I am now going to play the role that Hugh used to play. I have got that job that I've always wanted, permanent secretary at the Department of Health. And my new Secretary of State arrives, and he or she, almost certainly a he, the way our politics is, comes and says to me, so I've read the stuff, you know, I've read all of this, and I know the problems, right? It's zero real, demand goes up forever, so we need transformational change. And I say to the Secretary of State as permanent secretary, all cats are dogs, right? All cats bark, therefore all dogs bark. Now, at this point, probably the Secretary of State picks up the phone to the Cabinet Secretary and says, can I have a new permanent secretary, right? The reason I'm saying that is because quite often the premises can be wrong, but the conclusion can be right. So, and I'm going to argue the conclusion is absolutely right, that transformational change is needed. The two premises are wrong. Zero real. Let's start with that. Money. As I used to be Permanent Secretary of the Treasury, I know a bit about money. Zero real is not a sustainable issue, right? We know it's been 4 real since forever. And if you think about what individuals or society wants to spend on health, actually you're going to at least want the same share of your income. So it's going to be related to GDP. But probably as you get richer, you're going to want a little bit more than that. So you're talking about 2 for real GDP per capita growth over the last, so let's project that forward. 0.5% population growth, we know that's about right from the ONS projections. And then you've got some compositional effects because of aging. So, you know, for maybe efficiency stuff, but Julian's going to sort that out, right? Now, so the zero real's not right, but it might be for a few years. So you need to think quite carefully about that. So quite a lot of the things you want to do are things which are going to improve matter, increase well-being now without using a lot of money. This brings me to the second part. So demand is inexorably going to rise. Well, why? Minister says, I read this thing, it said 80% of deaths from major diseases are due to lifestyle factors. I don't know if that's true or not. And I heard in the breakfast I was at that 30% of clinical interventions are either useless or harmful. So, you know, there's quite a lot we might be able to do here. And the important point is, it's all about people. Remember, your job, Secretary of State, is to increase well-being for everybody. We're not talking about patients now. It's a really important thing. It's about people. So we want to look at those lifestyle factors, so we want to change behaviours. So what can we do? Well, we all know the things that are kind of bad, like smoking, alcohol, exercise more, you know, all of those things. Well, in smoking, we really went at it. I mean the Treasury, right? We solved smoking because we put the price up. Right? The rest of you just fanny it around. We put the price up. We increased tax. On alcohol, we've kind of shied away from that. So why aren't we thinking about big increases in tax? When you go to the Chancellor, which is going to be your first move, I recommend, Secretary of State, you've got to do some stuff about how you're going to raise some money. He's doing all sorts of stupid things, right? He's not saving the planet because he's going to give you a break on VAT for energy. How dumb is that? He's also giving a subsidy to pornographic magazines. How dumb is that? Asian babes, 0 rated for VAT. Children's clothing, 0 rated for VAT. These are all stupid, right? There's plenty of money. There's 100 billion in tax expenditures, right? Plenty of money. We just need the political priorities. You should go there and say, here are all the things I want to do which change behaviour, which are going to get you more money in the long term. One of the things while you're about it is look at the mental health issue, right? You're going to sell to the Chancellor what we call in the trade a Del-Amy switch, right? Because he's spending a lot of money on disability benefits. A lot of people on disability benefits are there because of mental health reasons. If we get them back out of being on disability into work, you save the benefit and you get their tax. This is fantastic. The rates of return on this are great. So there's a lot we can do. Right? So let's just start doing all of those sorts of things. Behaviour change. So we need a big nudge unit. We've got one at the centre. Why haven't we got one in health? Let's have a nudge unit that starts to look at behaviour, starts to look at what are the things we could really do that will do big changes for everybody. Right? And I haven't talked about the health system. We can apply some of these changes to the health system, but Julian's the expert on that, and he can talk about it. The other point to remember along the way is that there'll be some perversities in this system. So, I was in Singapore lecturing on behaviour change, And they had this lovely program, which they called their frequent flyers program. They've got these people who go in and out, these old people go in and out of hospital, and it was like, oh my God, what can we do? And the answer was nothing to do with hospitals, go to the home. So they sent some people to the home, they sorted out why they were tripping over this big ledge all the time, while their things were quite dirty and they were getting diseases. So basically a little bit at home, frequent flyers were reduced quite dramatically. Great. Think about some of your metrics though. So you're keeping out of hospital some of the people who had quite short stays because they weren't too bad. So the average length of time people are staying in hospital goes up, not down. The other point about some of the things we're doing in the health sector, and it's probably my last point because we haven't got very long, is to say quite a lot of what we're doing, and this is where the regulators are coming in, is we're incentivizing stuff, doing. Now what I want to do is have my people, because of I want to improve their well-being, is going nowhere near really dangerous places like hospitals, right? I want them nowhere near you. I don't want them as part of the health system, thank you very much. So actually, if I achieve that, I'm going to reduce the output of the health sector as measured by our wonderful GDP numbers. And if you think about it, this is a real problem. We had this problem in the fire service, right? I remember talking to a great economist called Tony Atkinson, and we worked with the ONS, because the fire service, we measured the output of the fire service by the number of fires they put out. This is really dumb, right? And actually, as they got better and better, they put out fewer and fewer fires. As the health service gets better and better, it does less and less in the sense of the old-fashioned things which show up in the GDP numbers. So we need to be really careful about how we incentivize people to do the right sorts of things. And for me, it's all about trying to incentivize the right behaviors for the public, not just for patients. And then there's Secretary of State. I've talked to you about all of these things, so you're going to see the Chancellor, you're going to talk to DCMS and DCLG, and by the way, then I'm going to let you have a talk with the people who are going to talk to you about the health sector. And at that point, I will hand over to Julian.
Thanks, Gus. Well, let's keep on with this image of the minister has just come in, 2015, and he or she is talking to their permanent secretary. And for the moment, the idea of me replacing either Gus or Hugh as permanent secretary boggles the mind. But nonetheless, let's assume that for the moment I'm trying to respond to the minister. And the minister says, OK, well, I've heard about Gus's fantastic ideas. But what I really want to know is what's the experience of public sector reform? What have we learnt about public sector reform from the previous governments, from the Blair government, from the Brown government, from the Cameron, the coalition government? What are the lessons we've learnt? And can we sort of apply them to the way we take things forward? Well, I suppose one would say, Minister, well, there are indeed a number of lessons, quite effective lessons we've learned. The first lesson we've learned is money ain't enough. It ain't, in 1997, when the Blair government came in, it was told the real problem in the health service is money. All you've got to do is give us the money and rely upon the intrinsic motivation of staff, the public service ethos, the nightly motivations to drive things forward, and we'll have a wonderful service. Well, that died with Frank Dobson's Secretary of State experience. When they tried that, essentially, it really didn't work. It became clear that the lesson that you needed some form of challenge. And the question then became, well, where should this challenge come from, and what's the best form of challenge? A challenge that does not challenge too much intrinsic motivation, that doesn't have too many toxic side effects in terms of actually damaging the motivation and morale of staff, but in some sense it reinforces and encourages it. Well, the first thing that the Blair government tried was to move towards, basically the challenge came directly from government, directly from the department. Targets and performance management, and as it became known as, and many of you will experience this, targets and terror. And the interesting thing about that, Minister, was that actually it worked. Terror often does work. At least it worked in a crude sense. But most of the targets were met. The NHS targets were met. In fact, I think virtually all of them were met. But the trouble was that really there were too many toxic side effects. I mean, you all know some of the problems with targets, all about hitting the target, missing the point. And all the point about the demoralization and demotivation of staff subject to this heavy regime. So, on the whole, Minister, I wouldn't recommend that you go down the route of having heavy departmental intervention, heavy departmental targets and control. So, where else do you look? Well, you could look at the regulator or at the regulators. Indeed, that's the experience that we're now experiencing, is we're moving from a system, we're moving towards a system of fairly heavy-handed regulatory control. The problem with that, and of course there clearly has to be some regulation is important, no one deny it. The problem with that, Minister, though, is that particularly the experience as experienced under the Cameron government, we probably have too many regulators. We have overlapping regulators. We have overlapping regulators delivering a series of rather often conflicting messages. In some cases, I've been hearing stories about one regulator delivering completely contrary messages from different parts of the body, same body. And at the same time, of course, I mean, under the Cameron government, we have a problem of as we may have heard yesterday, of a fairly interventionist department as well as the regulators. And so the active agents, the hospitals, the medical facilities, are accountable in so many different directions to so many different commanders. We've got command and control, but too many commanders. So on the whole, Minister, I think I would recommend that you start sorting out the system of regulation and making it much clearer, much simpler, and less heavy-handed. So that still leaves the question, well, where does the challenge come from? Well, the other route that the Blair government went down was to look at the challenge from patients. And it looked at two areas of, two ways in which patients could provide the necessary incentive for improving quality. One was via voice, the instruments of voice, and the Blair government sort of flirted, and the Brown government flirted with voice, but the mechanisms of voice, community health councils, various links, various patient and public fora and so on. I don't think its heart was ever really in it. Really the mechanisms of voice were not really developed or encouraged. Instead it went down the route of choice, with patient choice and provider competition. It so happens, Minister, that I was a bit involved in all of that, and it won't surprise you to hear that I still believe, contrary to Andy Burnham or whatever, that actually that is probably rather a good way to go, and that Andy Burnham also incidentally gets his facts wrong. He said the evidence was that competition raised costs. Competition does raise costs in insurance markets. Competition in insurance markets raises costs. But the evidence is that competition with fixed prices, both from the US and the UK, actually raises quality while keeping costs constant or actually reducing costs. So one route for you, Minister, is to reinvigorate the choice and competition agenda. Patient choice has I think eroded in the past few years. Clive Smee was commenting earlier about how the extent to which you're seeing that choices are being increasingly limited rather than encouraged. But that is one way to go. But finally, Minister, one other sort of challenge you might think about is not just empowering patients, but empowering staff. Under the Cameron government, there's been quite a drive towards what are called public service mutuals. That's to say, employee-owned enterprises delivering public services that spin out from the public sector. In fact, we now have of the order of 80 live public service mutuals delivering across the public sector, delivering about £1 billion worth of services, and many of them are in health. They're mostly in community health services, one or two in acute. There's a Circle, of course, operating in acute. But really the potential, and there is some interesting work going on this, is perhaps for trying to encourage the empowering of staff through mutualisation in the acute sector. Lots of evidence across all sectors, across all countries, that employee ownership or employee engagement, strong degree of employee engagement, employee control, actually significantly increases the quality of the service being provided as viewed by the users, and it increases staff morale, improves productivity, and improves the general performance of the institution concerned. So, my recommendation to you, Minister, is to empower patients, empower the staff, disempower the regulators, and disempower yourself. I'm sure that will go down very well. Thank you.
Well, thanks very much. Now, while the Minister and the Permanent Secretary are deciding which other ministers and Permanent Secretaries to talk to in order to improve the health and well-being of the population, there are some people out there actually trying to do that. What I want to reflect a bit on is where we are in relation to the reform we've just been through or are still in the process of delivering, and then what does that mean for my job on the ground day to day and many other people like me, both in the health and the local government sector and beyond. So first of all, thinking about the health reform that we've faced to date, the advent of CCGs and in particular the engagement of GPs in the debate about health and care and the well-being of the citizen is really, really positive. And I don't know why we didn't do it before. I mean, GPs and social care were probably engaged in places, or the practice nurse was engaged with a social worker somewhere, but this strategic level of engagement has huge potential to make a difference, and certainly where I work, and I know from colleagues elsewhere in the country as well, it's the passion of some of the people we heard yesterday talking in the integration session and others, some of the GPs that are really taking this forward with their colleagues in local authorities. So that's really positive. The Health and Wellbeing Board's been mentioned, and that has huge potential, I think. The problem, of course, is we've got 152 of them, and they won't be fantastic everywhere. But they do have potential to provide and to build to be a vehicle that we could use to deliver whatever the Minister and the Permanent Secretary decide they want in the end. But what they have got to do, and they take different forms in different places, but one of the key things is they've got to make sure that they engage people who aren't on it. Yeah? So if your Health and Wellbeing Board is reasonably compact, and reasonably compact in any area is probably at least 15, if you've just even got all the commissioning and all the statutory people on board, you've got to engage with your providers, otherwise you won't be moving forward. So engagement with providers, voluntary, independent sector is critical. Now, the complexity of some of the other structures that have come out of the reform is a bit of a hindrance. You know, there's lots of things that I don't quite understand what they do and what role they play in the system, and I'm invited to things and I think, well, where does that fit in? I mean, I've got a role as a co-chair of one of the PM's champion groups on dementia, and working out who's doing what on dementia through the system is interesting. And the mismatch of incentives that we discussed a little bit in the regulatory session this morning doesn't always help us moving forward. Having said that, you know, I think, you know, we take the good out of what's there. The resource context is a huge challenge, but perhaps presents us with a rare opportunity. I went to meet with the health chief executives in the west of Hertfordshire earlier this week, and I took with me a paper which is a list of 9 areas of potential cross-cutting opportunity, which are not all about health and care. They're quite wide-ranging. I'll come on to them in a minute. And actually, I thought, well, I'll be interested in a couple of these. But actually, they were interested in way more than that. And actually, the chief exec of the Acute Trust said, I'm in. You know, so I'm talking about, should we have what about, let's consider the concept of a Hertfordshire civil service. So instead of saying, oh, we, the county council, can do stuff for you other people out there, could we actually think about this differently? We all need support services and a range of services. Could we work together and maybe we could have a joint venture or something which would deliver us something different to provide the support all our organisations need? Now, you know, we may never get there, but actually what there is in the system, because of the challenge and the context, is a willingness to consider, a willingness to look at concepts and take them to business case and beyond. And we won't deliver them all, but we will deliver some of them. what I would also say is that if we're thinking about health service reform, reform of the health service, and this has been referred to already, requires reform outside of the health service. We won't get healthier people by having better hospitals. We will get healthier people by the housing they get and whether they've got work and so on. And equally, reform of public services requires reform beyond the public sector. So we are talking here about engagement of communities, we're talking about behaviour change and participation of citizens. And actually, if you want people to look after themselves better, the best person to deliver your well-being is you. You might need a bit of help from time to time, but we've got to get people to understand that. So on the ground, thinking about taking forward that broad agenda across wide ranges of public sector agencies, there's a huge need for leadership, and the question is, where does it come from? And in different places, it will come from different organisations. It depends a lot on the relationships and personalities, the trust that you've got in your local area and how you can take things forward. But so leadership and trust are critical. We need to, if you talk in business terms, we need to be talking mergers, not acquisitions. This is about working together. It's not about takeover or we do this better and who's going to do which bit. It's the right thing to get the outcome. And we will need to look to new models, but skills of diplomacy and skills of relationship building are at a premium in this. And we all need to, one of my biggest tasks is to tread carefully. There's a real, if I disenfranchise people before we've even kicked off some of these joint projects, I've had it. Okay, so I need people on board. So in my area, in Hertfordshire, I was the Director of Adult Social Care for the last about 10 years. And now, strangely, I'm the Director of Finance and other corporate things. So I'm sort of a bit poacher turned gamekeeper. So health and social care integration is kind of top of our list of cross-cutting things to do, partly because we've got to do it, because we've got the Better Care Fund, we've got drivers which say we have to go that way. What we will do is go beyond what is expected. And that's a world that I've come from and have worked significantly in. But actually, we need to think about other things. And the core of health and social care integration is largely looking at that older population. But there's a whole load of other people out there who could benefit from wider public sector working together. So one of my strands of work, I've got 9 cross-cutting work themes that I've kind of got a mandate from the council to drive forward with partners. And I'm out talking to those partners. I've got at least 18 public sector statutory partners to engage, 10 district councils, all the different health organisations. I need the DWP there, I need probation, police, I need the prison service. Because one of my strands of work is adults with complex needs. So this relates back to the mental health example back there. So the hypothesis is that there are a set of people out there who, a bit like the Troubled Families programme, but actually they're not in families. They may be young single men or women. They're people that have fallen by hard times or families have broken up and so on. And they are drawing on a range of services. Quite a lot of them will have an underlying mental health problem. They may be homeless or they may have tenancy problems from time to time. So housing is a big issue. They may be involved with the criminal justice system. They certainly will be involved with DWP and so on and so forth. And there's probably a cohort of those which is not huge, but actually draws down on the public purse all over the place and never gets a good outcome. Because probably a lot of these people are nobody's top priority. They may not even be eligible for some things. But if you bundle it up together, you've actually got something different. And if you can get, 50%, even 10% of those people into work, into productive activity, into homes, contributing to communities, and actually quite often if you can help people through that, they will be great advocates and supporters and peers for other people who want to do the same. And there are people doing those sorts of things. There are social enterprises, charities like Turning Point are working in Hertfordshire on exactly that client group. But we need to do more. So that's one of my cross-cutting strands. I've got one on family-focused working. So, OK, Troubled Families programme. It's called Thriving Families in Hertfordshire. So we're taking that forward. It's getting some good outcomes. Work is the biggest challenge. So of all the outcomes that have been delivered, the fewest successes have been achieved in getting a member of a family into work. But actually, the criteria for that programme are quite tight. It's about children out of school, contact criminal justice, out of work, and so on. What if we were to work in a family-focused way with all the families we work with? So that we didn't have the adult worker over here in the mental health trust doing this sort of mental health work and the children's worker looking at the child protection issue over here. What if we were to have teams which were more we talk about multidisciplinary teams around older people, around GP practices, but what if we did that around families? So that's another one of my strands of work. Now, some of the others are more sort of slightly drier. So the Hertfordshire Civil Service concept is drier, but actually has got huge potential, and it's sort of trying to take something that everyone says we should do and look at it in a different way. I've got another thread which is on skills, jobs and work opportunities. And there are others. One I particularly want to mention to you is a thread called Enabling Citizens and Communities. And for us, that's inside the council, it's really important, and we will be driving that forward. But actually, we could do it with partners as well. Because what it's about is everything from channel shift, i.e. making really good use of the web to allow people access to services, either transactional services or just information advice or signposting. We've got an e-marketplace in Hertfordshire on which you can buy care, but you can also get a gardener or financial advice. Channel shift to be efficient, but also to deliver good customer service, right through to community capacity building. So what's the role? We can't do everything, and we actually aren't even going to commission everything, but we can enable things. We can be people that have levers we can pull to support the person in the community that's got a good idea, or enable the person in the community to know that they've got a good idea, because actually sometimes it's even that, people have got ideas about how things will work better, but they don't think that they could take it forward. So community capacity building, but using volunteers, working with the voluntary and independent sector, drawing in the right skills for the right purpose. So those are the kind of things that I'm doing day to day on the ground. I've just written 20 letters are going out today to, each one is different to our different partners about different asset rationalisation projects that we're going to do, mainly focused around town centres and use of the public sector estate in town centres, and actually not just trying to solve a problem, but to try and create opportunities, because we often work together to solve a problem, but we could be sitting there with a huge opportunity which we don't identify because there's no problem associated with it. So we're going out to look for opportunities as well as solve problems. And also this week we will be inviting all our partners to a cross-cutting piece of workshop to kick off the piece of work around adults with complex needs. And I'm looking at different ways to lever each thing. So we've got a voluntary organisation doing that work for us about scoping and scaling. Who is it? Who are the people? What's the cohort? And how could we take it forward? On the civil service, I'm talking to the East of England LGA, who've got a tool called a Solutions Centre, which is about bringing partners together to look at, can we get to the point of having an outline business case of moving forward? So different tools for different purposes, different leadership. We will have to invest, and times are hard, but if we don't invest in this, the rest of the work we've got to do, well, there's a day job over here, which is we've got to deliver loads of savings as well, 100 million. And this is not going to get me my next year's savings or the year after or potentially the year after. It might be the year after that these sorts of things kick in, if ever. But if we don't start them, we won't get there. And we really will be in difficult territory in 4 years' time. So I hope that gives you a flavour of the kind of things that I and people like me are doing on the ground with, hopefully, people like you. Thanks very much.